Assalamu alaikum wa rahmatullahi wa barakatuh. Our lecture today is about subcutaneous filariasis. We will talk about parasite Larvae. Objectives: classify filarial worm infections, define subcutaneous filariasis, identify common name of the parasite, name of disease, geographical distribution and habitat, describe the morphology of the parasite, understand the mode of infection, describe the life cycle, explain the incubation period, discuss signs and symptoms of the disease, explain the methods of diagnosis, describe the treatment, and explain prevention. Filariasis is a parasitic disease caused by an infection with roundworms of type Filarioidea. These are spread by blood-feeding insects such as black fly and mosquitoes. Filariases are divided into three groups according to the part of the body they affect. Number 1. Lymphatic filariasis is caused by the worm Wuchereria bancrofti and Bugia malayi. These worms occupy the lymphatic system, including the lymph nodes. In chronic cases, these worms lead to the syndrome of elephantiasis. Number 2. Subcutaneous filariasis is caused by parasite Larvae, the eyeworm, and the parasite Onchocerca volvulus. These worms occupy the layer just under the skin. Larvae causes Larvae filariasis, while Onchocerca volvulus causes river blindness. Number 3. Serous cavity filariasis is caused by the worms Mansonella perstans and Mansonella ozardi, which occupy the serous cavity of the abdomen. Parasite Durofilaria mitis, the dog heartworm, rarely infect humans. Subcutaneous filariasis Larvae. The common name of this parasite is African eyeworm. Name of disease Larvaeosis or Larvae filariasis is a skin and eye disease caused by the nematode worm. Larvae parasite doesn't normally affect one's vision, but can be painful when moving about the eyeball or across the bridge of the nose. Geographical distribution. Human Larvaeosis is restricted to the rainforest and swamp forest areas of West Africa. It is estimated that over 10 million humans are infected with this parasite larvae. Natural habitat. Adults live in the subcutaneous tissues of humans. The adult worms, which usually stay in one tissue, release early larval form, known as microfilariae, into the person's blood. These circulating microfilariae can be taken up during a blood meal by an insect vector. In the vector, they develop into infective larvae, which is called microfilaria larva 3, that can be spread to another person. In the human host, Lua larvae migrate to the subcutaneous tissue, where they mature to adult worms in approximately 1 year, but sometimes up to 4 years. Adult worms migrate in the subcutaneous tissues at a speed less than 1 centimeter per minute, mating and producing more microfilariae. These images showing the worm Lua. This is the adult worm in the eyeball. Morphology. Adult Lua worms are sexually dimorphic. Males are smaller than females. This image showing the adult female. This is the anterior portion with head, and this is the posterior portion with tail. Anterior portion has buccal tube and esophagus. This is the posterior portion, contain uterus, and this is the site of anus. These images showing the adult female. This is the site of vulva in the anterior portion, consists from muscles, and there are 2 uteri, anterior and posterior uteri. The first one containing eggs, while the second one containing microfilariae. And this is the uterus containing microfilariae. These are images of male, adult male. This is the anterior portion, revealing the presence of funnel-shaped mouth in the anterior region, and the ventral curvature of the tail region. ونلاحظ وجود الانحناء البطني في الجزء الخلفي من الجسم. This is microfilaria in the blood. Can be distinguished from other filariae by the presence of sheath and large number of nuclei that extend to the tip of the tail. This is the tail and the body of microfilaria filled with nuclei, which are coarse and crowded nuclei. From the beginning of the body, from the head to the tail. And we can see this microfilaria surrounded by sheath. Life cycle. The infective stage to human is microfilaria larva 3. When the vector, which is insect, genus Chrysops, takes blood meal, larva 3 enter the body through the bite wound, convert after a period of time to adult male and adult female. After mating, produce microfilaria, which is, as we said, sheathed microfilariae that are found in spinal fluid, urine, sputum, peripheral blood, and in the lungs. It is considered the diagnostic stage of this disease in human. When Chrysops takes a blood meal from this infected person with sheath microfilaria, it will take microfilaria with the blood. Microfilariae shed sheaths and penetrate midgut and migrate to thoracic muscles, convert to larva 1, molt تعاني من الانسلاخ, convert to larva 3. This larva 3 migrate to head and fly proboscis, which is structure found at the tip of proboscis, and repeat the life cycle. Incubation period. This period of time is variable and can be as short as 4 weeks or as long as 8 to 16 months. Signs and symptoms. Some patients can develop lymphatic dysfunction, causing lymphedema or lymphatic obstruction, which is a long-term condition where excess fluid collects in tissues causing swelling. The lymphatic system is a part of the immune system and vital for immune function. Fluid called lymph circulates within the lymphatic system. This is lymphedema, and this is the image of lipedema. Another signs and symptoms of disease, which is episodic angioedema, Calabar swelling. It is a transient subcutaneous swelling, marking the migratory course through the tissues of the adult worm of Lua under the skin, and disappears a few days later. It is about 3 to 10 centimeters in surface area, sometimes erythematous. When chronic, they can form cyst-like enlargements of the connective tissue around the sheaths of muscle tendons, becoming very painful. The swellings may last for 1 to 3 days and may be accompanied by localized urticaria and pruritus. Dead worms may cause chronic abscess, which may lead to the formation of granulomatous reactions and fibrosis. This is the image of Calabar swelling in the face, around the eyes. And this is the image of Calabar swelling in the hand. Transmission. Lua infective larvae, larva 3, are transmitted to humans by the day-biting mosquito vectors, genus Chrysops silica and Chrysops dimidiata. These carriers are blood-sucking and day-biting, and they are found in rainforest-like environments in Western and Central Africa. Infective larvae mature to adults, which is larva 5, in the subcutaneous tissues of the human. Diagnosis. Number 1. Visual diagnosis by seeing Calabar swellings, which are the primary tool for visual diagnosis. Number 2. Visual diagnosis of the adult worms under conjunctival tissue. Number 3. Microscopic examination of microfilariae is a practical diagnostic procedure to find Lua. It is important to know the time of blood collection between 10 a.m. and 2 p.m., which is the suitable time of appearing in the peripheral blood, and reach their maximum number at around midday. نلاحظ أنه أنسب وقت لأخذ عينات الدم لغرض التحري عن وجود المايكروفيلاريا in the peripheral blood بالنسبة لطفيل اللولوة هو تحديدا بين 10 صباحا إلى 2 مساء، الوقت الأمثل لوجود المايكروفيلاريا في الدم. ولكن بعض الطفيليات على العكس من طفيلي الوشرية بانكروفتي نلاحظ العكس تماما، أنسب وقت لأخذ عينة الدم تكون بين 2 صباحا و10 مساء. Blood sample can be thick smear stained with Giemsa or hematoxylin and eosin stain. Concentration techniques can be used. These include centrifugation of the blood sample, lyse in 2% formalin, or filtration through nucleopore membrane. The other way of diagnosis, antigen detection using an immunoassay for circulating filarial antigens, constitutes. Number 5. Subcutaneous biopsies. Identification of adult worm is possible from tissue samples. Number 6. Skin test antigen. By injection of antigen of Durofilaria mitis for filariasis diagnosis. If the patient was infected, the extract would cause an artificial allergic reaction and associated Calabar swellings. In theory, by metabolic products of the worm or dead worms. Prevention. Because Lua is long-lived, more than 20 years, and adult females can produce 12,000 to 39,000 microfilariae per day. Primary prevention is focused on reducing the near constant exposure to the Chrysops in endemic regions. Number 2. Diethylcarbamazine has an effective prophylaxis for Lualua infection. The recommended prophylactic dose is 300 mg, given orally once a weekly for 8 weeks. No vaccine has been developed for Luiasis. Treatment. Number 1, chemotherapy. Number 2, surgical removal of adult worms, followed by systemic treatment. The drug of choice for therapy is diethylcarbamazine, or called hetrazine. The recommended dosage is 8 to 10 mg per kilogram per day, taken 3 times daily for 21 days for adults and children. We could use ivermectin. The recommended dosage is 150 microgram per kilogram in patients with low microfilaria load, with densities less than 8,000 microfilaria per milliliter of blood. يعني في حال وجود أعداد الميكروفيلاريا أقل من 8,000 مايكروفيلاريا في المليليتر الواحد من الدم، ممكن استخدام علاج الآيفرمكتين. Albendazole in patients with high microfilarial load. Treatment with diethylcarbamazine and or ivermectin may be lower initial dose as the rapid microfilaricidal actions of the drugs can provoke encephalopathy. In these cases, albendazole administration has proved helpful. Center for Disease Control and Prevention recommended dosage for albendazole is 200 mg taken twice a day for 21 days. A visible subconjunctival worm requires removal. This can be safely done by making 2 mm incision in the conjunctiva tissue and extraction of the adult worm with a pair of forceps, followed up with systemic medications, as we see here in this image. This is the adult worm in the eye. Procedure. A worm in the subconjunctival space may quickly migrate out of sight. First, it should be grasped externally with forceps to prevent migration. Subsequent subconjunctival injection of 2% lidocaine with epinephrine, 1 to 100,000, can then be used to numb the region and paralyze the worm. يتم استخدام اللايدوكين والابنفرين لتخدير المنطقة ولشل حركة هذا الطفيلي. A peritomy generally less than or equal 5 millimeters allows reach to the paralyzed worm, which can then be removed with a second set of forceps. Postoperative care by combination of systemic diethylcarbamazine or albendazole with topical steroids and antibiotics. نكون بهذا السلايد انتهينا من محاضرتنا لهذا اليوم المتعلقة باللوا باراسايت. السلام عليكم ورحمة الله وبركاته.